brought to you by the Orthopedic Research and Education Foundation India. Today's webinar is going to be on medial collateral ligament injuries of the knee, and we have a sports injury specialist from Paras HMRI Patna, Dr. Arvind Gupta, who's going to talk to us about the medial collateral ligament injury in the knee. As you are all aware, there have been a lot of development in many of the ligamentous injuries around the knee, and to keep abreast with it is important, and therefore all of you should be paying attention to the talk, so because this is going to be important even for your examinations. So over to you, Arvind.
Thank you very much, sir. Thank you again for the opportunity. So let's start sharing the screen.
Sure. Full screen.
Yes, sir. So my talk will be on the medial collateral ligament injury and its management. So on the medial side, the stabilizer, the mainly divided into the dynamic stabilizer of the knee and the static stabilizer of the knee. In the dynamic stabilizer, if you see, it's the adductor magnus tendon, there is semimembranous tendon, that is very important, the gastrocnemius tendon. In all these, the semimembranous is most important one, which attaches over the posteromedial aspect of the tibia. And along with the valgus secondary stabilizer, there is its action in knee flexion also, as well as in knee internal rotation of the tibia also. Then there is adductor magnus, which attaches over the adductor tubercle, and the gastrocnemius muscle, which originated from the gastrocnemius tubercle also. So a relation of all these tubercle is very important, particularly at the time of reading of MRI, as well as if we are planning for the surgical treatment. So if you see the adductor tubercle, it is around 12 millimeter proximal, as well as 8 millimeter posterior to the medial epicondyle. Next is the gastrocnemius tubercle. It is again around 8 millimeter posterior to the adductor tubercle, and around this is 13.7 millimeter posterior to the medial epicondyle. So all these tubercle is very important for surgical point of view, as well as the reading of MRI. Then there is a static stabilizer of the knee. That is the main thing. That is the medial collateral ligament. So medial collateral ligament having three components. One is the superficial MCL, then there is deep MCL, and then posterior oblique ligament, that is also called as POL. We'll see one by one. And this, the medial collateral ligament passes deep to all the pes, that is sartorius, gracilis, semiti, as well as semimembranous over the proximal part of the tibia. So we'll start with the superficial MCL. So this superficial MCL is around this 10 to 12 centimeter in length. And deeper to that, there is deeper MCL, that is deep medial collateral ligament, and both superficial and deep is called as the medial collateral ligament. And if you see the attachment of this collateral ligament, superficial collateral ligament over the medial side, so it is almost around 5 millimeter posterior to the medial epicondyle area, as well as almost 3 millimeter proximal. So this attachment is again very important. And if you see the deep MCL is there, deep MCL attaches with the meniscus also with the help of meniscofemoral ligament, as well as the meniscotibial ligament also. and this remain deep to the superficial collateral ligament. And this superficial collateral ligament having two attachment. One is proximal attachment, that is attached just below the joint line. Another is distal attachment, that is almost around 4 to 6 centimeter below the joint line and in the posterior half of the tibia. If you see the sagittal plane, so it attaches in the posterior half. It's not in the anterior half. So again, this attachment knowledge is very important for the time of repair or reconstruction, so that the natural isometry of the ligaments should be achieved. And this the proximal part of the superficial MCL. So basically, it's having action in prevention of the valgus opening of the knee joint. And if you see the distal part, so this is the distal part of this superficial MCL. So this ligament is having rotatory stability. So in this view and this, if you see if this knee is getting rotated externally, so this get tight. So this is the little bit loose, and if you see this get tight. So this is this having a role in rotatory stability around the knee, both in the external as well as internal. So this is the posterior oblique ligament next. So this attachment is little bit posterior than the superficial collateral ligament, and almost around 6 millimeter posterior to the attachment of this superficial, as well as around 7 millimeter distal to the attachment of the adductor tubercle. Also having relation with the gastrocnemius tubercle. So this is in relation to the gastrocnemius, and this is how it's overall it looks. So this is the superficial collateral ligament. This is the deep collateral ligament, and attachment of the posterior oblique is more proximal and posterior. This is the medial epicondyle area, you can see it. And both superficial as well posterior oblique ligament is posterior to that and little bit more proximal to that. But both the ligament attaches distal to the attachment of the adductor tubercle as well as the gastrocnemius. And this is the semi-membranous. This is having 5 limbs for the attachment of the femur and the tibia. So this is the cadaveric dissection of this posterior oblique ligament. So this is the superficial part, and this is the posterior oblique ligament. And if you see the action of this posterior oblique ligament, so this acts as a restraint to the internal rotation of the tibia, particularly at the 0 degree of the angle. At the same time, this also provides the valgus opening of prevention of the valgus opening of the knee joint at 0 degree. Superficial MCL act mostly with highest capacity at 30 degree of the knee flexor. And this posterior oblique ligament provide prevention of the valgus opening at 0 degree of knee flexor. So if you see the action is prevention of the valgus as well as the rotation. So in the extension, the posterior oblique ligament, and in the flexion, particularly 30 degree, the main stabilizer for the valgus is the superficial medial collateral ligament. Then in the rotation, there is internal rotation and there is external rotation. Again, internal rotation at extension, that is the posterior oblique, and at flexion, this is superficial medial collateral. And the external rotation stability, that is usually it is initially said by it is the posterolateral corner that prevent the external rotation of the tibia. But in a recent study that is published in 2020, and it is well researched, said this medial collateral ligament, particularly the superficial MCL, all these posterior oblique and all these having this prevention of the rotation of the tibia around the knee joint also. So this was in the extension, now this is in the flexion. So about the incidence of the MCL, it is almost 60% of all knee injury. So MCL is the ligament which torn maximally in comparison to all the ligament or meniscus around the knee joint. So almost 60% of the knee injury is because of MCL injury. but mostly get healed. That's why it's mostly don't get the documented. And the mechanism is many a time direct blow that leads to the valgus, or maybe because of the valgus and rotational stress from the pivoting over the knee joint. So this is how, this is the valgus as well as anteromedial rotation of the tibia leads to the injury of MCL, as well as anterior rotation leads to injury to the ACL also. And in this fashion, in MRI, you can find edema of the lateral femoral condyle and the lateral tibial condyle also. In the tests should be done at 30 degree. So this is basically testing for the superficial MCL and the deep MCL. And at 0 degree, this is for the posterior oblique ligament. And always check for the opening on the medial side. And by clinical test, if opening is 3 to 5 mm, then it's grade 1. If opening is 6 to 10 millimeter, then grade 2. And if opening is more than 10 millimeter, then it's grade 3. So this is the clinical, but the radiological also, that is X-ray. In the X-ray, if you put the stress over the knee joint, a stress valgus test, and it's usually done at the angle of 20 degree. So if at 20 degree, opening is 3.2 millimeter in comparison, so it's called as the grade 3 injury. And if opening is almost 10 millimeter, almost 1 centimeter, it means the injury to the both superficial MCL, deep MCL, posterior oblique ligament. So opening only 3 to 4 millimeter, then it's injury to the superficial MCL only. That is grade 3, but it's grade 3. But if it is more than one or more than 1 centimeter, it means all the 3 structure are torn on the medial side. So nowadays, a stress X-ray is taken as one of the main criteria for making diagnosis of MCL, particularly in chronic cases, not in the acute cases, because in acute cases, patient will have a lot of pain while doing this things. So another classification that was given by Wigston, that is quite long time ago, almost in 1976, it was published. It was grade 1, grade 2, and grade 3. So in grade 1, it's just the local tenderness. There is no instability. So there will be tenderness along the MCL, but hardly there will be opening of the joint. That you can see here in the MRI, there is little bit of edema on the medial epicondyle, but continuity is maintained, hardly any injury. In grade 2, there will be localized tenderness, as well as there will be partially tear of either MCL or POL or both. So that is grade 2. So here you can see there is continuity, but you can see in the proximal part of the MCL, it's not very clear. So it's the partial tear, but continuity is maintained. In grade 3, there is complete disruption as well as instability on applying of the valgus stress. So here you can see the continuity is lost, the MCL is wavy. So that is the complete tear of the MCL. So it is grade 3. This classification was given by Wigston. So now in the grade 3, you can add the clinical opening that you measure with the valgus stress. So that is, if +1 it is, that is 3 to 5 mm of laxity, +2+ is 6 to 10 millimeter of laxity, and 3+ is more than 10 mm of laxity. So in that grade 3, you can add 1+, 2+, 3+. Also, that stress X-ray that we have discussed, lot of literature over that about the stress X-ray role in diagnosing of MCL. Again, 3.2 millimeter opening, or 1 or more than 1 millimeter or 1 centimeter opening with the stress X-ray. Then in the diagnosis, X-ray is another important point, particularly in the chronic MCL tear. If such type of calcification you can see, so this is called as Pellegrini-Estrade disease because of this chronic MCL, and there will be calcification around the MCL at medial epicondyle area, or many a time there will be in the adductor continuity of this calcification, maybe in adductor magnus. Also, in diagnosing of avulsion, there is breach in the medial epicondyle, and if you ask for the CT, again you can see this injury, and in the MRI you can clearly diagnose it. So again, avulsion type of injury you can identify with the X-ray. But MRI is the gold standard, which can identify with the partial tear, just a strain, or partial or complete tear. And also in acute cases, you can, along with this MCL injury, you can very easily pick. This is the superficial MCL that is torn. This is the deep MCL you can torn. So most of the time you check it in the coronal plane only. So this is the meniscus injury. This is the ACL injury. And also in the axial section at the medial epicondyle area, you can see there is avulsion of the medial collateral ligament attachment. Here in the MRI, you can see this is the MCL and this is the PES. PES, you can see it. So MCL has came superficial to the PES. So here, this type of picture you can many a time, particularly the tibial avulsion side, you can find it. So if this came superficial to the PES, that is the indication for doing the surgery for it. Because if it comes superficial to the PES, this is hardly going to heal with the tibia. So another avulsion, particularly the deeper side. So here, the deep MCL, this is called a meniscofemoral ligament. This can avulge from here, or this can avulge from here. You can see from the tibial side, it is attached. Avulsion is there. So this avulsion injury can be easily picked with the MRI. At the same time, by doing orthoscopy, drive-through sign, more than 1 centimeter opening on the medial side, maybe on this tibial side or maybe femoral side. If opening more on the tibial side, that is injury of the MCL on the tibial side is there. If opening more on the femoral side, it means injury of the MCL is on the femoral side. So about the treatment, so most of the grade 1 and grade 2 injury of the MCL can be treated conservatively. Almost every grade 1 and grade 2 can be treated conservatively with very good outcome. Grade 3, that is complete tear, many a time it can be managed conservative also, but many a time it needs surgical treatment, particularly if it is associated with other ligament or multi-ligament scenario, if there is bony avulsion injury, or if you have managed complete tear conservatively, but still instability is there, then this is a case for surgical treatment. In the surgery, you can go with the direct repair also in early acute cases. So like this is the case you can see here. So this is the MCL, that is complete tear of the superficial MCL also, and the deep MCL also. And again, there is a injury to the MC. This is the ACL also. You can see the empty nose sign on the lateral side of the tibia. So this is after the reconstruction of the ACL. Still there is, you can see the significant opening on the medial side, and that was confirmed orthoscopically also. Even after reconstruction of the ACL, there was opening of almost a centimeter. So in this case, so this was, you can see on the medial side, the skin incision was placed, and just after putting the incision over the deep fascia, you can see how this superficial MCL that was avulged. You can see this is the complete avulsion of the MCL from the medial epicondyle area. So here you can see it. And also you can see a deeper, there is deeper MCL avulsion is also there. So this is, this was the significant injury that we appreciated on MRI only. So in this MCL, bite was taken, and nowadays we have advantage of this swivel lock. So all this is the fiber wire that was taken, a stitch taken through that avulge part, and all these has been passed through this. And this is that's why the anatomy knowledge is very important, so that you should be putting exactly where it's has to be placed, so that the isometry of the ligament is maintained. And this is how it's get completely repaired, covered anatomically at its place. And you can see here, this was the medial epicondyle area in this area here. So you can see that this fiber lock and ACL was reconstructed. So this was another case, again, complete avulsion of the MCL. So this was a repair with the help of suture anchor only. So suture anchor was placed, and then this suture anchor is having needle with this. So this was complete repair at its natural place. Nowadays, there is concept of augmentation with fiber tape. So extra articular ligament get augmented with fiber tape, even ACL also. So this once it get repaired, so you just pass one soy block with the fiber tape here, and then you check for the isometry. This is the flexion and this is extension. So in isometry, the length of your fiber tape should not be changed. And at that place, you should again doing this swivel lock. So next is the MCL reconstruction. So on the medial side, again, at the isometrical point, bead pin, this is how I do bead pin pass. Then this get reamed with the 4 mm complete reaming through and through. Then the outer cortex get reamed with the 10 millimeter of the reamer. So this the medial cortex of the femur is taken off, and then this is the cancellous screw with a spike washer, and this is the double gracilis tendon is there. So that is taken, rolled over the spike washer, and once this part done, so it's not completely tightened, then a artery pass just below the pes, and then this get railroad over the tibial part. Usually it is around 4 to 6 centimeter below the joint line. And this is again with the help of this bead pin, which get removed the 4 mm reamer, and then a spike washer pass, and this both the strand get crossed over this spike washer, and this get final tightened. At the angle of around 30 degree of knee flexion with valgus. And you can see it gets completely compressed between the surface of the tibia and the spike washer. This patient was also having ACL injury. This was the chronic one, so that's why in this case and you can see the isometry was checked. And this is the X-ray of this patient. So this was the ACL, and the MCL reconstruction was done. Most of the time I do for the superficial only, particularly the chronic one. Many a time you can have to put a suture anchor here also for the deep part, as well as you can do this posterior oblique reconstruction also, as described by the Lapra. So the conclusion is there. Tear of MCL are the most common injury around the knee. Incomplete tear and isolated grade 3 tear most of the time can be treated conservatively. Failure of non-surgical treatment may require the reconstruction of the MCL. And the acute, most of the time in acute cases, repair is the treatment of choice. The primary repair is usually based on the quality of the ligament as well as the time since the injury. And most of the time, primary repair should be performed within 2 weeks.
Okay.
If you find the tissue quality is not good, you can augment with the help of fiber. And if that ligament don't get healed, either conservatively or primary repair, you should reconstruct the ligament. Thank you.
Yeah, thank you very much, Arvind. I think that was very well explained and gave enough time to the diagnosis part, which I think is the most important part in these injuries. One question is, you said it's the most common injury of the ligaments in the knee. What about ACL? When you compare to ACL, is it more common than ACL injuries? Because in practice, we see a lot more of ACL injuries than MCL injuries.
Yes, the MCL is the most common. Most of the time, grade 1 and grade 2 don't get
They never come to us.
So literature says, yes,
So
they never come to us most of the time. Or even they came, we usually treat with a simple analgesic and little bit of rest. So in 3 to 4 weeks, they get fine. So that's why they don't get MRI and they don't get this documented. And valgus injury, one of the most common injury around the knee. That's why another reason behind this common ligamentous injury of the knee.
And the other thing which I noticed during this last meeting we had is a lot of people were talking about the tibial part of the medial collateral ligament having to need surgical procedures more often than the femoral part. And what is the reason for that, and why is that more common?
So on the femoral side, there is a lot of blood circulation is there. So chances of healing is high. On the tibial side, blood circulation is less. And many a time it get entrapped over this pes anserinus. Yeah, so that's why the chances of healing of the tibial part is less in comparison to the femoral side.
So that is the superficial part of the ligament. So the deep is...
that is the most common ligament. So if there is injury to this MCL, so most of the time first superficial get injured, followed by deep, and then posterior oblique ligament most of the time.
So any other questions from the delegates? EMB. You're muted, Janki. We can't hear you.
Just checks.
Yeah, now we can hear you.
Okay, sir. So, as you mentioned, sir, sometimes you only suture the superficial MCL, repair the superficial MCL.
For reconstruction, you mean to reconstruction or?
Yeah. In case of repair, sir.
Repair, okay. So in case of repair, most of the time, if there is avulsion of the superficial part, you just repair it. Deeper part, even if it is torn or posterior oblique part, if you left it, this get most of the time healed because of lot of surplus, particularly on the femoral side. But if you able to repair all these ligaments simultaneously, like in second case of this, that was complete avulsion and that was repaired with the suture anchor. So if you can, then you should repair it. But also keep in mind, many a time on the medial side, any surgery having very high chances of stiffness also. So that has to be keep in mind also at the same time. So if you are doing lot of things on the medial side, so chances of stiffness will be high.
The reason for the stiffness?
So reason for the stiffness is exactly what is the theory, I don't know. But maybe because of this lot of the circulations and vascularity, if you do lot of things, then inflammation will be high. So that leads to inflammation. That leads to stiffness.
So Rajan has asked about when there is mixed ligamentous injury, is there any protocol for conservative treatment?
So it's depend upon your approach. So if there is multi-ligament injury, suppose a case of ACL and MCL. So it's your approach may be acute or it's maybe after some time. So if you are doing acute surgery, then you after doing ACL check for the valgus opening. If any valgus opening less than 1 centimeter, you can manage conservatively. MCL can get healed with the time. If it is more than 1 centimeter, like still there is superficial POL and this deep MCL component is completely torn. Because with ACL, many a time, even with the grade 3 only superficial MCL, you can see opening is almost a centimeter. Because ACL also gives stability for the valgus. So once you have reconstructed the ACL, then check for valgus opening. If it is more than 1 centimeter, then you should be doing surgery for your MCL also, but most of the time repair or augmentation. But if you want to delay the surgery, that is another good thing. So give the brace exercises for 6 weeks, 6 weeks to 2 months. Check for the valgus stability. If many a time only superficial MCL get healed with the time, and after that 2 months or 3 months you can go ahead for ACL surgery. If it is superficial MCL with deep MCL with posterior oblique ligament, then the chances of little bit of instability will persist. Some part get healed, some part may remain unhealed. So that you can deal at the time of ACL reconstruction also. So there is two type of approach, particularly with multi-ligament. Many a time you go directly in, then you do all the intra-articular part, either repair. Nowadays there is concept of repair also and reconstruction, or meniscus tear is there, you should repair. And then after doing all these things, check for extra-articular ligament, that is MCL ligament. If opening is more, then you should be doing repair. If it is less, then this can heal with the time.
Yeah, and also it also depends on the patient. Okay, so if you have professional sportsmen, they can't afford time off, so you need to get them moving early. Also, they're motivated to mobilize their joints, so the chances of them getting stiffness are much lower. While in the average patient, the general idea is to get back movement and then do your ligamentous reconstruction. So that's a broad guideline. It isn't true for every particular patient, but that's what we go by.
So Dr. Pratyush has asked about how to decide whether MCL and ACL and meniscus repair should be done in one sitting or in multis, means two or three sittings.
Did he ask MCL or ACL and medial meniscus only?
So MCL, ACL, and meniscus.
Okay.
Okay.
So basically, if meniscus is there and it is in the red zone, nowadays there is recommendation for early surgery. So you should be doing ACL and meniscus at the same time, and remaining part you should be assessed again clinically after doing these two, ACL and meniscus. If any valgus instability a centimeter or more, then you should be doing the repair of MCL also at the same time, if it is acute situation.
And there seems to be a there seems to be a general feeling that if you have an ACL injury, then your meniscal repair is more likely to work because of the growth factors which come in from the bleeding from the ACL injury. But
so I usually have a confusion.
If it is a chronic situation, suppose ACL, meniscus, and MCL is there, then you should be deciding whether this meniscus is going to heal or not. So according to that, you should be taking the call.
Yes, sir. Sometimes, sir, during approaching a fracture, you fix the MCL with washer. If you cut it, then in that case, usually the post-operative protocol is that same, sir. Range of motion should be started as soon as pain subside, or we should wait.
I mean, if you do a avulsion injury,
yes,
if it's an avulsion injury with the medial epicondyle and you fix it with a spike washer and a screw, idea would be your fixation should be secure enough to allow you early mobilization.
So, and when we are using the conservative treatment for MCL, then how much time we should wait to start the knee moving?
Range of motion should be started. There is nothing like the range of motion brace should be given to the patient, and the slowly it should be increased. There is nothing like you should not be doing range of motion. Only thing, weight bearing should be delayed for 6 weeks.
I think in all ligamentous injuries, early movement is important. And this is one of the things you found out with ankle, the lateral ligament injuries. People used to put them in a cast for many weeks. I think the idea is not to keep them in a cast for too long and start early range of motion, proprioceptive exercises, etc. And they tend to heal faster.
So even if it is sprain grade 2, we can do range of motion exercise as soon as.
Absolutely. You brace them for a hinged brace kind of thing, but you start range of motion.
Good evening, sir. Sir,
Yeah.
I'm Sachin here. Sir, in case of sir in TKR, if there is medial collateral ligament injuries, what do we do further proceed, sir?
For TKR?
Yes.
Yes.
Accidentally injured the medial collateral ligament.
So you can do the reconstruction at the same time, or you can use the semi-constrained or fully constrained type of thing. If you think your reconstruction of MCL is good enough, tissue is good, bone purchase is good for the ligament, so you can go ahead with the reconstruction at the time of MCL injury in TKR.
And the most important thing is to avoid injury to the MCL when you're doing your TKR.
Yes, sir.
Okay. So if you should try and avoid it, and if it does happen, then you should be prepared to reconstruct it.
So in that case, if there is valgus thrust, that when MCL is loose, then in that case, what usually you do with MCL, sir?
Valgus thrust.
Like when during the TKR, sir, if the patient is having lax MCL, in that case, what should be done, sir?
So lax MCL, I mean, are you trying to say that there's a medial collateral ligament injury before that?
Not the injury, sir, but if sometimes it is lax, like
for the valgus knee,
yeah.
valgus knee, you mean to say?
Yeah, in the varus knee, sir.
Varus knee MCL don't get lax. Most of the time, it lacks in the valgus knee one.
Yeah.
Oh yes.
It gets stretched out in the valgus knee. In the varus knee, it's actually tight. You need to release it to get back adequate opening on the medial side without damaging it. Okay.
So one thing at the time of this MCL injury during TKR, you should not be using the thicker poly if you want to do repair by somehow. So your poly should be thin so that this ligament length is not get too much, it's lengthened, so that there should not be a stress on the either repair or reconstructed MCL. So
yeah, but having said that, we more often than not use the minimal size poly anyway. So it becomes difficult to reduce it further unless you have one of those joints where you have every millimeter size of poly, then it's a little easier, but it becomes difficult to change the size of the poly if you're already using a minimal size poly. But if you are using a thicker poly, then maybe a thinner poly may be used. Because usually this happens once you notice it after you've done your cementation or whatever.
So,
okay.
Just one question about the indication of repair and reconstruction. So maybe mixed up.
Again, as repair in acute setting, if it is there in avulsion injury or associated with a multi-leg injury, and you are going for the surgery, and it's the acute injury and complete injury to the superficial, deep or POL or professional athlete and all these, those who require early surgery should be treated with the repair one. Rest should be given chance for the healing, particularly for the MCL. And for 6 weeks to 2 months, you should be checked. After that, if this get healed, then good. You should be continue with the exercise, physio, rehab. If this don't get healed, then this requires the reconstruction.
Just one thing, sir. Sir,
How many just one things do you
no,
have?
sir. May I request for a no, sir. Like so many terms have been used, like a sever lock and suture anchor and all. If we can plan one class about that instrument and that implant what we use
Nowadays, there's
whenever you
a
have, yeah,
lot.
because
Yes.
it is difficult for the DNBs because in
Yeah,
few
to attend.
centers it is not frequently done.
So they should
But,
attend the surgeries and then they will know what it is, okay?
yeah,
I mean, this
Yes,
is no
yes.
excuse for having a class on various types of swivel locks, okay? They should attend the surgery and they will know what it is. Okay.
thank you very much, sir.
Okay.
Thank you.
Okay, bye. Thanks very much.
Thank you, sir. Thank you for
Yes,
the.
Thank you, sir.
Bye.